And this is to introduce you to hearing from people who are clinical experts at Yale, either clinical science, clinical researchers, or clinicians, and what they are doing at Yale. The first person that I want to introduce is Dr. Michelle Johnson. She is a professor of radiology and biomedical imaging and neurosurgery. She got her MD from Temple. She is the director of interventional radiology and neuroradiology, which is, if you don't know how unusual it is to be an interventional radiologist as a woman, an interventional radiologist in neurology and neurosurgery, it's like so rare. And she is considered an expert. She goes all over the world because of her expertise. And another one of her claims that we're so proud of, even though it took so long, is she's the first African-American woman to become professor at Yale. So we are so proud of her, Michelle Johnson. Thank you, Michelle. Are you on the next one? Yeah.
Thank you so much for allowing me to be part of this. We'll see if I can intervene and make my slides work. So I sort of decided to title this Trailblazing in Medicine, and I was the fortunate recipient of a Trailblazer Award from SNMA and the Latino students last year, which made me think a lot about what I've accomplished. It isn't accomplished alone, and so under disclosures, I wanted to say that I'd like to acknowledge the contributions to my career and fund of knowledge from my teachers, my colleagues, my friends, my family, and my patients, without which I wouldn't be here. So you got my background. I was at Temple. I have here this quote from one of my two female radiology mentors in medical school, Mary Stuart Fisher, who said that the way you look at x-rays is you describe, discuss, and diagnose. And as an aside, she used to say, well, everybody would come down to go over films in the old days, the good old days, and you would look at the film, you're trying to look at the film, and they're telling you this story. And she would look, and then she would say, could you just go over that again? Because she really wasn't listening to them. She was looking at the films so that she had the answer by the time she heard that again. And just for those of you who don't look at x-rays all the time, this NG tube is in the right mainstem bronchus and down in the lower lobe of the lungs, so it's kind of a good thing to be able to recognize. So my first, my first job after I finished radiology residency at Temple, I went to University of Pennsylvania for a 2-year fellowship in neuroradiology, which was a combined both diagnostic, including pediatric, and interventional training situation, because there really weren't interventional neuroradiology fellowship training like there is now. And so when I was ready to have, I had my first child during fellowship, and I was secretly trying very hard not for anybody to know that I was pregnant as I was leaving the fellowship too. And so my second child was born during my job, and I went back to Temple on the faculty, and it was the perfect job. It was 2 days of chest, 2 days of neuro. I took call for neuro. I had an academic day on Wednesdays. My office was a converted darkroom, which was about a little bit bigger than this podium. And the good thing, they couldn't pull me from one area to another. And after my second child was born, you know, how did I get into neurointervention? And I'm going to paraphrase Mary Pollan and say it fell in my lap. While I was on maternity leave with my second child, I found out that my chief had decided to go to the University of Michigan, and he was the interventionalist, and the chief of neurosurgery sent me flowers and said, congratulations on the baby and congratulations on being our new interventional neuroradiologist. And so, you know, I was brought up by parents who were both research chemists. My mother was my father's graduate student TA. I was going to be a research chemist and then decided after 2.5 years of undergrad that I would trade the BS for the BA and go to medical school instead. And so I always thought that you could do anything. My parents brought me up to think you could do anything. So what an exciting time in a new and rapidly growing specialty of interventional neuroradiology. The catheter guys would come in and they'd say, oh, I have this variable thickness catheter, want to try it? And I would go, I'll try it. And, you know, when we were there, I had a ENT surgeon and a neurosurgeon that were about my age, and we worked together, and we developed good patient care, good camaraderie and collaboration, and I think that's really set the tone. So when I started going to national meetings of the interventionalists, one of the senior guys told me this in February, and I must say I didn't actually recognize it, that I was the only woman. I was the first woman that showed up for these meetings. But they never treated me like a girl. They treated me like somebody else who was showing you, oh, well, we were trying to put this balloon here, and it went there, and then we went how to go get it out. Those kinds of things in a morbidity and mortality conference, I went to that conference as an equal, and I was treated as an equal, and I don't know which of those came first, but I never felt like the fact that I was a black woman in an all-white male field was important at that time. But now I've got 2 kids, and the next thing I moved from Temple to the Medical College of Virginia, and this is Halloween of 1992, and this is my new September infant, my daughter Erin, who I think is in the audience, and my son Brandon. And Halloween was a big deal. Like, you've got kids, you've got to do intervention, you've got to read films, but you've got family. And so every year I'd pull out that sewing machine and we would do Halloween costumes. So I'm sharing a few of those pictures with you. So what is interventional neuroradiology? Well, I have like 3 slides of listing of things, and I'm not going to read these to you, but basically what we're doing is in the head, neck, and spine, we're using small catheters or needles to be able to do non-invasively what was formerly only done by open surgery. So a couple of examples. Here's a patient with a ruptured aneurysm, and here you can see on the CT scan there's an area of hemorrhage. The ventricles are enlarged. I know there's Joe King's in the audience back there. There's a frontal pericallosal aneurysm. For those of you who aren't neuroradiologists, if you look at this angiogram, that aneurysm looks like a Matchbox car, doesn't it? It's got, like, here's the trunk, here's the trunk and here's the hood. Anyway, you can take the microcatheter from the artery and the femoral artery, take it up through the system into the pericallosal artery, and put platinum coils in to exclude the aneurysm from the circulation. That technology, the first GDC coil, came out around 1994, 1995. So this is really new technology. So I arrived at Yale from Medical College of Virginia in April of 1999 as the director of interventional neuroradiology. I had 3 kids at the time, and they were in 3 different schools: elementary school, 8th grade, and 10th grade. My partner and neurosurgical mentor who hired me left about 2 to 3 years later, and for about 6 years, and thank God it was before the explosion of thrombectomy for stroke, I was the sole interventionalist for neuro. And so, I had 3 kids. I didn't go very far. I lived 2 miles up the street. It was all convenient, and it all seemed to work. And the kids were very flexible, and one of them would come in and bring lunch to the angio suite when we could do that. Now we can't bring food in there. And then subsequently, there were new neurosurgical partnerships, guys who have dual trained in both neurosurgery and endovascular techniques. Radiologists being less interested in doing the crazy things that gave me such joy in my career and training. And that's changed my workflow, and it's changed the environment. And I put here in green that continuous change is a part of everyone's career. The key is that there has to be willingness and strength and perseverance to make the most of these change. Some people, change makes them feel disenfranchised. You've changed my world, I can't do my thing anymore. And some people, change is an empowerment. I'm going to take this on as a new challenge. It's going to be a new way to reinvent myself in order to make it work. And so I would encourage you guys to think about ways that that works. I think if I wasn't able to reinvent myself, I'm still a cat, but at least we've got a Power Ranger, and everybody's not a pumpkin in 1995. here's another, interventional neuro lesson. This was a 9-year-old who was in status epilepticus, and this hemorrhage actually occurred on the CAT scan table. It was Charles Duncan's patient. We took the patient to the operating room, and the little arrow, I think you can see it better on this view, is a little pseudoaneurysm that had occurred. And this picture is a roadmap. This is the microcatheter out in that artery where we're able to inject a small amount of liquid crazy glue into the area to exclude it from the circulation and stop the bleeding. So again, these are things that I learned over time that really changed patient life. So at this point, I didn't say at this point that I was a single parent at this point, so I'm managing the 3 kids, the job, the interventional, the neurosurgeons, and or at least I'm managing my interaction with the neurosurgeons. And we still managed to find time to do something cool. So this is us at Atlanta in 1996. Miles was 4 at the time, and we managed to find time for good times in between the busy times. For Dr. Vining, who I hope is still here, I work a lot with the ENT surgeons. This is a patient with oral bleeding, and you can see these metallic, these are brachytherapy seeds, and you can see this area right there where there's a little funny blush of contrast. That's this lingual artery pseudoaneurysm, and again, a little crazy glue in the right place stops the bleeding. These are often very traumatic. There's blood everywhere. There's lots of people in the room. Everybody's trying to do everything. And so interventional neuroradiology is literally on the pulse of what happens. And that, again, it's something that it's just given me great joy to do this. And yes, it's hard, and yes, the hours are long, and yes, it's all worth it. So again, we got to Hawaii, so we've been able to do a little something. And the last, I'm going to finish up by saying that, we learned over time that if it works in the vein, the TPA that people give for stroke, then the clot's in the artery, then radiologists decide to go to the clot directly. And so it's like Willie Sutton in the bank. You go there because that's where the money is. So I want to share with you this patient, and I won't go through too many details. But this is a patient who came in. He was a non-smoker who had some dysmetria. And here is a very bright basilar artery, and the red arrow is showing you the occlusion. We put an aspiration catheter in. We got the clot out. You can see the follow-up CT where there's no hyperdense basilar. He does have a cerebellar stroke. And this is him the next day, but with his permission, with his hands up in the air. So we really make a difference. So my final points, my advice, my themes or thoughts from my career, you have to believe. You have to believe in yourself, in your abilities, in your talents, and in your ability to overcome adversity, because adversity is going to come. You have to have excellence in choosing the right path, keeping a glass half full mentality. You have to have strength. You have to be strong enough to take chances, strong enough to lead, and most importantly, be strong enough to ask others for help. You can't do it all by yourself, even if you're the only one, even if you're one day in the corner of the angio suite, I had a pillow and a blanket on the floor, and anesthesia came in to help resuscitate the patient, and they thought they were resuscitating me, and I said, no, I'm just going to take a nap until you do your thing. And then finally, there was a lot of talk. Dr. Kinder talked about mentoring, and I want to mention mentoring and sponsorship. So mentors are not just people senior to you. Mentors are your teachers, your classmates, your colleagues, your students, your family, your friends. The guy who does the cleaning, who might give you a positive word when you're finishing your case. All of those people you can gather strength from. And sponsorship are those people who say, oh, I saw that junior faculty person. I think she'd be really good on the program for this thing I have control of, and you can put somebody, you can support somebody and push them along. Coralie Shaw, Shirley McCarthy, Ann Curtis did that for me in radiology. We need to do that for each other, both up the line and down the line. You young people, don't forget that the senior faculty often feel inadequate, like they have imposter syndrome, like they're never going to get to do anything again either. So with that, I'm going to end with my family. My father passed a few years ago. These are my 3 kids now. And this is my mom, who's 95 years young. Thank you so much.